Thank you, Mike and Dan, for this kind invitation to speak here. So my job is to talk about diminutive colon polyps. I mean, whether we should resect and discard or leave alone. These are my disclosures. So diminutive polyps are defined as polyps that are less than equal to 5 millimeters in size, and they are very common and seen in about 70 to 80% of all the polyps that we remove are diminutive polyps in colonoscopy. And we take them out, send them for pathological examination, basically to differentiate whether they are hyperplastic or adenomatous, and because that will then dictate the future surveillance intervals for that patient. But this comes at a huge cost burden that is associated with colonoscopy. So if you look at the prevalence of diminutive polyps, and this is just a snapshot of some of the studies over the last couple of decades, you see that the number of diminutive polyps that we find per patient undergoing screening exams is anywhere from 0.21 to 2.61 diminutive polyps per patient. So quite a wide range, but definitely around at least one or more than one diminutive polyp per patient is detected. If you look at the histology of these diminutive polyps, about 40 to 60% of them are low-risk adenomas. And the rest are either hyperplastic, sessile serrated polyps, or other benign histologies. So if you look at the hyperplastic polyp, it's about 25 to 40%. Sessile serrated polyps or adenomas are much less common in this size range, and other benign histologies are fairly common too. Now, what is more important is, of these diminutive polyps, how many of them have advanced histology, which is defined as either the presence of villus component or high-grade dysplasia or cancer. So again, some of these similar studies have shown that the incidence of advanced histology, or the prevalence of advanced histology in these polyps, is kind of very low. So it ranges from 0.1% to about 18.6% for high-grade dysplasia and villus. The 18.6% study is kind of an outlier. If you see most of the studies are showing that the advanced histology is less than 3 to 4%. And more importantly, there's hardly ever a presence of any cancer in these diminutive polyps. So what do we know about the natural history of these diminutive polyps that are so common? Again, there is limited data. Most of the studies have followed these for 2 to 3 years because, it's difficult to do such studies. You see a polyp, you're tempted to remove them. And to do a study where you keep doing colonoscopies to see how they are developing is kind of difficult to do. The longest follow-up study was by Mizuno et al., which had a mean follow-up of 7.8 years. And what they found was that of the 207 adenomas less than equal to 5 millimeters in size, only 2 of them progressed to advanced adenoma during the follow-up period, and none of them advanced to cancer during the follow-up. So recently, a systematic review was published in GI Endoscopy, in which 9 studies were included that followed these polyps, the diminutive polyps, over a few-year period. The mean duration of follow-up ranged from 1.8 to 7.8 years. And only one diminutive polyp was found to progress to cancer during this time period. Only 6% progressed to advanced adenomas, although because the follow-up period was rather short, we still don't know what the long-term transition rate to cancers is, and longer-term follow-up studies will be needed, but as we can understand, these are very difficult to accomplish. So diminutive polyps are common. A significant proportion of them are either hyperplastic or have other benign histologies. If you have a diminutive adenoma, it is very unlikely to harbor advanced histology, and cancer is even rarer. And they're less likely to aggressively grow into cancer over a short period of time. And removal and histopathological examination of these diminutive polyps is used as a risk stratification tool for surveillance recommendations. And all of you should be familiar with this. Whoever does colonoscopy should be following some guidelines, and this is the guideline that we follow for follow-up recommendations. If you find small tubular adenomas, 1 or 2 small tubular adenomas, then you bring the patients back in either 5 or 10 years. If you have 3 to 10 small tubular adenomas without advanced histology, or with advanced histology, you bring them in 3 years. Whereas if you have small hyperplastic rectal or rectosigmoid polyps, then you bring the patients back in 10 years. So what is the current practice? Current practice is we resect all the polyps we find and send them for histopathological examination. The only caveat is if you find pale, small hyperplastic polyps in the rectosigmoid, you usually sample a few and don't remove 10, 15 of these because you have a high suspicion that these are hyperplastic. And then based on the histology recommendations, you recommend the future surveillance intervals. Now, there are several drawbacks to this strategy. Main is the cost burden to the patient and the healthcare system with very limited health benefits. There's also risk of complication from avoidable polypectomies for hyperplastic polyp, although the risk is very low, but there is still a finite risk from these polypectomies. There's delay in recommending the surveillance intervals. You come out and tell the patient that you've removed some polyps, he'll have to wait for you to get back to him, and that causes a little bit of anxiety. You have to go back into the patient's chart and look at the histology and then generate a letter, which is kind of inefficient for the endoscopist, takes up a lot of time. Sometimes the polyps are removed and are not retrieved during the procedure. Then you're left with a polyp that was there, and you don't have the histological diagnosis to make a recommendation. And the other thing is that we kind of ignore pathology is not a perfect gold standard. We always consider pathology as the final say, but we have seen in multiple studies that the accuracy of pathologists for these polyps is around 90%. So it is not the gold standard, but it is a reference standard. So because of all this and the development of advanced imaging technologies over the last few years, there was a paradigm shift that was being discussed and is still being discussed is what we call optical diagnosis. What it means is you characterize the histology of these diminutive polyps during the procedure. So you detect a polyp, you use an imaging modality, which could be electronic chromoendoscopy or chromoendoscopy, and you characterize the histology of the polyp. And then what can be done is, and this is for diminutive polyps only, and then what can be done is you can resect and discard this polyp and use your optical diagnosis to recommend the surveillance intervals. And the second concept is the do not resect strategy, and this is for diminutive polyps in the rectosigmoid that you characterize as hyperplastic, and these polyps can be left behind because of their inconsequential malignant risk, and you can avoid doing a polypectomy in the patients. What are the advantages of these proposed strategies? The main advantage is the cost saving, and a couple of studies have been done to modeling studies to see how much money can be saved, and one study reported a saving of approximately $1 billion in the US annually. It therefore improves the cost effectiveness of colonoscopy, decreases the complications from reducing the number of polypectomies you're doing, especially for those rectosigmoid hyperplastic polyps, and also there is no delay in recommending the surveillance intervals to the patients, helps to decrease their anxiety, they don't have to wait, and also improves your efficiency as an endoscopist. So this paradigm shift has been discussed for a while now. A lot of studies have been done. Can it become standard of care? Till now, we are still resecting all these polyps and sending them to pathology. I mean, there are several things that have to be accomplished before it can become standard of care. The technology and the endoscopist has to be accurate in predicting the histology as well as the surveillance intervals. The technology should be easy to learn. It should be practical, hassle-free, should not be adding too much time to your daily procedures. Otherwise, it will be difficult to be incorporated in practice. It also should be economical. It should not be increasing the cost. Otherwise, it's counterproductive. It should be available. And most importantly, it has to be endorsed by our GI societies for medical legal support and backup. So the ASGE took the lead in this, and a few years ago, a task force was formed, which was called the Preservation and Incorporation of Valuable Endoscopic Innovations, PIVI in short, which kind of assisted in the development of this new paradigm to manage diminutive polyps and serve as a guide to researchers and also those who are developing these technologies. And this task force came up with 2 recommendations. The first recommendation, or the benchmarks or the threshold that was set, was if you use your high confidence endoscopic prediction of the polyp histology of diminutive polyps and combine this diagnosis with the histological diagnosis of rest of the polyps, because patients can have diminutive polyps as well as polyps that are more than 5 millimeters. So if you combine those two and then come up with a recommended surveillance interval, there should be a greater than 90% agreement between your recommended surveillance interval to that you could get from histological examination of all the polyps. So basically, the gold standard is the surveillance interval that is derived from the histological examination of all the polyps. And if your predicted surveillance interval is similar to that in greater than 90% of the times, then you reach this benchmark. And the second benchmark was for the diminutive hyperplastic polyps in the rectosigmoid. And if you can achieve a greater than 90% negative predictive value for adenomatous histology in these polyps that are diagnosed with, again, with high confidence, then these polyps can be left behind and not resected by you. So this is a quick recap of how we diagnose. The most common way of diagnosing these polyps, at least in the US, is using electronic chromoendoscopy. Most of the work has been done with narrowband imaging. This is a consensus classification that was described a few years ago, in which you look at the color, the vessels, and the surface pattern on these polyps. And based on that, you can make a judgment of whether it is a hyperplastic or an adenoma. So if the color is the same as the background, color of the polyp is the same as the background mucosa, or lighter than the background mucosa, that is suggestive of a hyperplastic polyp. If it is darker than the surrounding mucosa, then it is suggestive of an adenoma. If you don't see any blood vessels, which are dark brown structures on the surface of the polyp, then that is suggestive of a hyperplastic polyp. If you see these dark brown linear or convoluted structures on the surface, which are vessels around the pits, that is suggestive of an adenoma. If you see these dark dots evenly spaced out over the surface of the polyp, that is suggestive of a hyperplastic polyp. And if you see oval or branched tubular white structures, which we think are pits, then it is suggestive of an adenoma. Then recently, from Europe, there was a classification describing sessile serrated adenomas or polyps, which was not included initially in the NICE classification. And if you can see the surface is a cloud-like surface over here. If you have these features, indistinct borders, you can't see the borders very clearly. If you have an irregular shape, and if you have dark spots inside the crypts, then these features are suggestive of sessile serrated adenoma or polyps. And now we have a new classification which is called the WASP that has combined the NICE and this classification to have one big classification system for diagnosing a polyp histology. So the question then comes is, these thresholds have been set by the ASGE in the PIVI guidelines or the PIVI paper. Are these achievable? And multiple studies have been done, and this was a meta-analysis that was published, which said that the first threshold in which we talk about the agreement in the surveillance intervals was achieved, was basically you had a greater than 90% agreement in academic setting with experienced endoscopists, and when the optical biopsy assessment was made with high confidence. And then for the second benchmark, which deals with the hyperplastic polyps in the rectosigmoid, the negative predictive value for adenomatous histology also was greater than 90%, especially in academic centers with experts, and when optical diagnosis, again, was made with high confidence. So overall, the systematic review recommended that the endoscopic assessment of the histology of diminutive polyps, the benchmarks, have been met with NBI, with endoscopists who are experts in using this technology, and when the diagnosis is made with high confidence. Now, we've been talking about high confidence. What does it mean? High confidence is a subjective thing that how confident you are when you're making that diagnosis. And there are certain criteria that have been discussed about regarding the confidence level. One is that if you look at a polyp and you look at all these features that we just discussed about, and the polyp has features of one histology but not of another histology, then that's a high confidence diagnosis. Or if you, in your mind, more than 90% sure that this is either an adenoma or a hyperplastic polyp. Or if you can quickly make the diagnosis in less than 5 seconds. So these are certain features that tell you that, yes, this is a high confidence diagnosis. Now, a few years ago, the ASGE, the European Society for Gastrointestinal Endoscopy, also took the lead in this, and they have also endorsed that in certain strict controlled conditions, real-time optical diagnosis of diminutive polyps can replace histopathological diagnosis, but there are certain caveats. You have to use validated scales. The polyps have to be adequately photo-documented for proof whether they are adenomas or hyperplastic polyp, because you have to understand your picture, your high-definition picture, is kind of replacing the histopathological slide. And then the polyps this diagnosis has to be performed by experienced endoscopists who are adequately trained and are audited periodically. So what will it require for this to become standard of care or to succeed? We have to demonstrate competency and achieve the benchmarks that have been set, at least in the literature. There have to be formal training programs. Fellows who are going through fellowship have to be trained in this. There has to be ongoing reinforcement of skills. It's not one and done. You have to make sure that you are maintaining your competency, and that can be assessed by regular audits or auto-validation of your performance. And you have to be motivated to learn, because it does require a little bit of learning and practice, and also there is this inertia to change practice. So you have to overcome that. It has to be endorsed by professional GI societies, and we've seen that a couple of them have endorsed it, and also by local institution to provide mostly the medico-legal backup and backing. Financial incentives have to be developed, which is very tough. We have to develop CPT codes, lobby government and payers for reimbursement, because you are saving money, but there is no extra incentive for the endoscopist to be doing this personally. Now, bundling of payment, which could be the future over here, might be a motivating factor, which means that you're getting a fixed amount for the entire procedure, which includes anesthesia, pathology, what have you. So in that kind of a payment model, doing real-time histology and decreasing the number of polyps you're sending to pathology might be an incentive for the endoscopist. What are the obstacles? Main obstacle is the inertia, the lack of motivation to change practice, and the medico-legal concern. There's lack of financial incentive, obviously. Sometimes there's a financial disincentive, because a lot of practices own their own pathology, so sending less polyps means less reimbursement. Institutional policies have to be modified. You have to photo document and have to have a system to save and archive high-definition images, which is important not only for self and formal audits, but also important for medico-legal protection. So the main thing that comes up here, first you have to become competent, and then the main concern that lurks in our mind is there potential for harm when we are doing this? We are not sending these polyps to pathology, and using our own interpretation and judgment. The bottom line is that these are low-risk lesions. Okay, so the risk of harm or the potential for harm is very low if you're wrong. However, if you think about it, according to the second PIVI threshold, you have to achieve a negative predictive value of greater than equal to 90% for adenomatous histology. So you can have a 10% false negative rate and still achieve that benchmark or threshold that can allow you to pursue this paradigm shift. So what it means is 10% of the times you can diagnose an adenoma incorrectly as a hyperplastic polyp. So you leave that behind because you follow the do not resect strategy. Now you bring the patients back. If that was the only polyp the patient had, then you bring that patient back in 10 years, whereas if it was truly an adenoma, you brought the patient back in 5 years. So that gives a longer period of time for that adenoma to grow into an advanced lesion. But we have seen that over at least a short period of time, these adenomas, these diminutive adenomas, don't grow into cancer or develop advanced histology. On the flip side, if the hyperplastic polyp is incorrectly or diagnosed as adenoma, you're too cautious, every polyp that you see, you feel it's an adenoma, then you start removing these, and ultimately you'll recommend an incorrectly shorter surveillance intervals, because as you know, the surveillance follow-up is different if you have only hyperplastic polyp versus if you have adenoma. Now you're negating the cost benefit of this strategy. So in conclusion, diminutive polyps are very common, and they are low-risk lesions. The current practice is we resect these and submit them to histopathology, except that with the caveat that if you have multiple small, pale, hyperplastic polyps in the rectosigmoid, our current standard of practice is to sample a couple and not remove all of them. However, there is a paradigm shift that is being discussed and hopefully will be followed in the future, which is the resect and discard for polyps that are diagnosed with high confidence, either in the right colon or adenomas in the left colon by experienced endoscopists who have experience in novel imaging, or do not resect the diminutive hyperplastic polyps in the rectosigmoid that are diagnosed with high confidence by experienced endoscopists. Thank you.